Hello everyone, do you hear me? Hello.
Yes, we can hear you.
So, hello everyone, and welcome to the Prosthodontics webinar series. My name is Omar, and I am the webinar director at SCORE Committee. It's a pleasure to have you all with us today. Before we begin, I would like to briefly introduce the International Association of Dental Students, IADS. It is the largest global organization representing dental students worldwide, contacting students from different countries and creating a platform for academic exchange, professional development, and cultural collaboration. Through its programs and activities, IADS aims to enhance students' educational experiences while promoting global collaboration within the dental community. The webinars is organized under the SCORE Office of IADS, and the SCORE stands for the Standing Committee on Research and Education and stands and focuses on research, education, and international collaboration. Through SCORE initiatives, students have the opportunity to engage with experts, participate in global projects, and gain valuable learning experience such as today's webinar. We are truly happy to have you all join us today, and we hope this session will be insightful and beneficial for everyone. And I want to welcome Dr. Mohammad for joining this session today. Without further delay, I would now like to hand over to my colleague Safia, who will guide you through the next part of this webinar.
Hello, everyone. My name is Sofia, and I am the webinar coordinator for today's session. First of all, I want to welcome all of you and thank you for joining us. We are really excited to have you here, and it's a pleasure to have Dr. Mohammad with us today to share his insight and experiences. Dr. Mohammad bin Sulaiman is a highly skilled prosthodontist and dental lecturer at the School of Dental Science, University of Science, Malaysia. After earning his Doctor of Dental Surgery from University of Science Malaysia in 2016, he began his career as a dental officer in 2017. His appearance of excellence and him to attend the membership of the Faculty of Dentistry Surgery from the Royal College of Surgeons in Ireland 2022. In 2022, followed a Doctor of Clinical Dentistry in Prosthodontics from Queen Mary University of London 2023. In the same year, he has achieved membership in Prosthodontics from the Royal College of Surgeons of Edinburgh. In recognition of his experiences and detection, Dr. Mohammad bin Sulaiman was awarded the Specialty Fellowship in Prosthodontics by the Royal College of Surgeons of Edinburgh in March 2025. His clinical interests focused in comprehensive prosthodontics rehabilitation, managing complex toothwear, and dental implantology. We hope you all enjoy this session and find it both informative and engaging. Thank you, Dr. Mohammad, and all the floor is yours.
And thank you very much, Ms. Safia, for the introductions. Let me share my screen first. Is that my voice is okay?
Yes, it is okay. It's clear.
Yeah, great, fantastic. So I'm just going to share the screen now. Yes. Is the slides okay? Okay. Okay, cool.
Yes.
Yes. Just a second. Okay. Again, good afternoon, good morning, or good evening, wherever you came from to hear this probably 1 hour seminar. So in this webinar, we're just gonna talk. First of all, I would like to thank to the International Association of Dental Students for inviting me to just do a bit of sharings on this topic entitled "To Surface Loss: What Dental Practitioners Should Know." So, if you're gonna cover everything under to surface loss, it's gonna cost perhaps 1 day, 2 days may not be enough. But I'm just going to cover a bit of everything, so that whenever you later graduating or you currently working as a new dental practitioners, you should you're able to identify the two surface laws and perhaps formulate the plan for the patients, for the best interest of the patient. Okay, let's begin. Okay, so just a bit of sharing. This is me with my colleagues, restorative colleagues. This is when we completed the examination via the Royal College, from the Royal College Edinburgh at the Queen Mary University of London. This is me with my colleagues as well, with all our consultants. Here is Dr. Timfield, Professor Sidhu, Dr. Loshna, and also we have the Professor Shaki Shadat. So this is me last year when I attended the conference ceremony by Royal College of Edinburgh, receiving the specialty fellowship in prosthodontic with the Dean of the Faculty of Dental Surgery from the Royal College Surgeons of Edinburgh, Professor Grant. This is where I work. I work in one of the dental school, one of the university, University Science Malaysia. It is situated in Malaysia, in East Coast of Malaysia. If any one of you would like to come here to do attachments, so you are most welcome. You can always contact me through my email address here. So, okay, so let's begin. Why the two surface laws matters? If you look into the literature, it depends on where you came from. So basically, if you see into the track records, the two surface laws is in increasing prevalence worldwide. Because why? Because more patients are retaining the teeth even longer, due to our perhaps the awareness by patients and the lifestyle modifications. However, to understand, two surface loss is basically multifactorial and it can progress. So we as dental practitioner have to play our part in order to identify the two surface loss, and we can consult the patients so that the two surface loss is not progressive. It's probably stopped at the current stage, and it's often underdiagnosed if you look into the way that we screening the patient in our dental practitioner. Perhaps we tend to focus into shift complaint compared to scrutinizing or examining patient as a whole. Okay. So these are the outlines for our webinar today. I'm just going to talk a bit on the type of the surface loss and the etiological factors, which is important for you to recognize and identify, so that we can consult the patients and motivate the patient to stop their habit or what's or not. And we're going to talk on what to assess or what to examine in these patients, and what are the decision making in formulating the treatment plan into surface loss and the way that we manage the case. So just imagine this gentleman, 40 years old, come to you complaining of worn on and short teeth. This patient was worried about the appearance of his front teeth, which may look unpleasant, and he did not like smiling or talking to people because of the appearance of his short teeth. So what are playing in your head when you see this patient for the first time? So what are the habit that, of course, you're going to control the habit, and you're going to involve the patients in preventing further to surface loss, and what are our aim, or what are our role in order to treat or to solve the shift complaint. So we're just going to talk a bit on this case on at the end of the webinar. So if you look into the definitions, tooth surface loss can be interchangeably with the term tooth wear. It is irreversible loss of hard tooth substance caused by factors other than those responsible for dental caries. As we know, the dental caries is caused by acid, by the bacteria. So the tooth surface loss in general, we can say other than that. And if you classify the tooth surface loss, there is four main categories, which are attritions, abrasions, abfractions, and erosions. And however, if you look into the literature, most of the tooth surface loss usually occur in combinations. Okay, let's go one by one. What does it mean by attritions? So attritions is defined by the mechanical wear resulting from the mastication or any parafunctional habits. So basically, it is limited to contacting surface of the teeth. So you can see here is tooth-to-tooth contact, and you can see when you ask the patient to occlude or bite, you can see there is matching facets, which is corresponding to the worn down teeth. And you can see the incisal edge or the occlusal surface is sort of flat. So that is attrition. What are the etiologies? Most of it comes from parafunctional habits. For example, bruxism or clenching. It can also be caused by the premature contacts on or for example, mandibular movement or edge-to-edge occlusions or the crossbite, the isolated crossbite on the tooth which cause more attritions on that particular tooth. What about the abrasions? So abrasions, it is caused by an abnormal wearing away of the tooth substance caused other than mastication or other than tooth-to-tooth contact. So we can say abrasions is independent of the occlusions, and it can cause by any abrasive external object. For example, let's see the next slide. It can cause by for example, the habit from the patients which practice vigorous toothbrushing and they use incorrect technique of toothbrushings, or they use hard bristle toothbrush. Secondly, it can cause by the sort of occupational hazards. For example, dressmaking, glassblower, or musician. In dressmaking, for example, patient perhaps tend to bite the needle, and you can see sort of notches. This is quite classical presentations of the abrasion caused by the needles or any habits. For example, biting nails or eating any abrasive seeds, for example, sunflower seeds. You can see the notches here, and this is abrasions cavity caused by the vigorous toothbrushing or incorrect techniques. What about the erosions? So erosions caused by the chemical that do not involve the bacteria. So we can say the erosion caused by acids, which is not coming from the byproducts of the bacteria or the metabolism of bacteria. The severity of the erosions depends on the type, the concentration of acids, the frequency that the tooth exposed to the acids, the temperature of the acid involved, or the time contact with the tooth surface. Perhaps the longer the time, the more severe the tooth surface loss going to be. And if you look into the acid, what sort of acid it can be, we can classify the extrinsic acid or intrinsic acids. The extrinsic comes from, for example, the diet. Patient love to eat citrusy food or like to eat pickles or any to drinks a lot of carbonated drinks, beers, that gonna cause the erosions if it is not controlled. The medicines, for example, the chewable vitamin C. Patient like to chew, patient which is regularly take vitamin C, and he consumed the chew vitamin C quite longer period of time, that can cause the tooth surface loss, which is erosion. Or patient that work in certain industry, for example, patients that work in battery factory, which is exposed to certain acid fumes, and swimmer, which patients swim in sort of chlorinated pool, which can prone the teeth to eroded. What about the intrinsic? Intrinsic is coming from the acid from the inner part of the body. For example, regurg from the gastric reflux into the mouth, or patient have the medical problems such as hiatus hernia or gastroesophageal reflux disease or the esophageal diverticulitis. Or patient have psychological disorder, for example, bulimia nervosa, or patient with other medical problems, for example, peptic ulcer or morning sickness in pregnancy. So it's important for you to identify each of the causes, because these are the things you want to probe from the patient. You want to ask from the patients whether does the patient practice certain or taking certain acid or whatso not. And here, if patient have any medical problems, this is where you have to liaise with your medical counterparts in order to manage the patients with the surface loss. So what are the sort of clinical signs? So you can see if patient have the restorations, you can see the tooth surface loss involving only the tooth, and you can see the restorations. For example, in this case, is amalgam sort of stand up from the tooth, and you can see a cupping dentin lesions. So this is typical presentations, cupping of the tooth, typical presentations of the erosion. If you have the chance, you encounter these cases in this sort of presentation in your patients. And last but not least is abfractions. But however, abfractions is there's a lot of controversials, but we can say that the abfractions caused by the biomechanical loading forces, and it is thought a result from the fracture or chemical fatigue degradations, which can cause enamel and dentin worn down. If you were to compare the abfractions and abrasions, is perhaps more or less about similar, but if you want to see sort of distinct features, abrasions usually the cavity will be shallow compared to abfractions. You can see sort of very prominent V shape or very sharp edges, and it is even deeper than abrasions. However, it can come together. For example, patient has abfractions and also abrasion at the same time. That's why sometimes it's a bit difficult for us to identify single causes, but what is the more important, we identify it as to surface loss in order for us to consult the patients and sort of identify what are the probable etiological factors. So, like I said, it is controversial. It can be multifactorial, but some say that it's due to occlusal stress, tensile stress, and compressive stress. Some say due to occlusal interference on that particular tooth. For example, there is premature contact while patient do the escalating movement, or bruxism, clenchings, or any malocclusions that causes stress and that cause the presentations of abrasions, which is wearing down of the tooth. Okay, so as general dental practitioner or as dental students are doing their clinical practice, their clinical simulations, so you have to really master in doing the history taking in sort of patients. Okay, so when patient first came in, you have to understand the patient as whole, including the complete history taking. So what is the patient main concern? So is that about the appearance? For example, patient complain the teeth look short, and he's shy or she's shy to talk to people. So that is something that you want to ask. Does the patient have any problem in terms of the function, where the patient said that now he cannot eat certain food because he found it difficult to chew, or patient feel discomfort? For example, patient complain of hypersensitivity. The tooth got pain here and there. So there is something that you want to ask from the patients, because that is going to dictate your and going to help in your formulating the treatment plan. Okay, and in more about the history, you have, like I mentioned earlier, for example, the medical problems. For example, patient is diagnosed with gastroesophageal reflux disease or peptic ulcer gastritis. These are the etiology of the intrinsic acid, which can cause the erosions. Patient may have the certain occupation from the social history. Patient have the certain occupation that prone to patient having the surface loss, for example, wine taster, the swimmer, or those who work in battery factory. Or patient complain of parafunction habits. How can you ask? Perhaps maybe while you sleep, while the patient sleep, is there any noise heard by, for example, the siblings or those patient spouse that can hear any sort of noise when the patient is sleeping. You want to rule out if there is any bruxism or grinding. And because of the etiological factors of the erosions, we can say there is extrinsic acids. So you have to have a risk assessment by doing the diet history. It's advisable to do 3-day diet history or perhaps 1 week diet history to just rule out if patients love to eat something which is quite acidic or citrusy that can prone the patient to have more to surface loss. And more about the risk, the parafunction habits, gut dietary habits. And this risk is very important because you as the clinicians or general dental practitioner, you have to really identify or just narrow down the possible etiology of the wear. So, if you know what are the causes of the tooth surface loss, it will be easier for you to formulate the preventive measure for the patients. Because to start with, the treatment plan, the management of the tooth surface loss is basically you want to control the progressions of the wear. Okay, if let's say the progression is rapid, you want to slow down the progression of the surface loss, then only you can think of other managements. Okay. So from your history, from your examinations, you look into any signs. So you want to classify the etiological factors, perhaps from the intrinsic, and any mechanical, for example, mechanical tooth brushing, which is not right, and the intrinsic, for example, patient have parafunction habit, bruxisms. So these are the things you want to rule out from the patients by doing a thorough history and examination. So why I say it's important for you to really identify the etiological factors, because you may end up the tooth is not properly diagnosed, so the management is going to be not right. For example, in these patients, 10 years earlier, the diagnosis of bruxism was made. Okay, so the bruxism is something to do with parafunctional habits. So of course, in bruxism, we're going to give patient with mouth guard or any occlusal splint formation to wear. So what you observe here, so it's actually you can see wearing down of the splint, and also you can see there is no matching facets of the tooth. Like I described earlier, when you about to diagnose attrition, you can see sort of matching facet between the tooth. But in this case, which is not, patient not even can bring the tooth together. So in this case, probably patient suffered from other etiological factor, which is excessive consumption of acidic beverages. So by wearing the splint, it's gonna aggravate the problem, because the wearing the splint gonna pull the acidic drinks or anything that acidates into the tooth. Okay, so that's why I said identifications of etiological factors is mandatory in the tooth surface loss. Okay. So when you examine the patients, so this is where you're going to see whether the tooth surface loss is either pathological or physiological. What does it mean by pathological? It's actually it's atypical for the age of the patients. For example, you see this photo, the clinical photo, you see there is perhaps maybe erosions, maybe attritions. You see cupping lesions here and there. And you see these such cases in, for example, in 40 years old or 35 years old, which is not corresponding to the physiological age for the patient. So this is, we can categorize this as pathological. So what about this severe or moderate to surface? So tooth wear with significant loss, which is more than 1/3 of the clinical crown, we can categorize it as severe tooth wear. Okay, so again, if you see in the case, what are other things you want to see? You want to see whether the tooth surface loss is actively progressive or it is passive or stable. There's a couple of signs like you can see. If you see the surface texture of the tooth is shiny and glossy, it can suggest, it's not 100% true, but it can suggest it is actively progressing. But however, if you see the tooth with wearing down, wearing facets, but it's sort of stained and it's smooth, we can say that probably the tooth is actually, the tooth surface loss is actually passive or perhaps stable. Most of the patients with actively progressive tooth surface loss come with dentin sensitivity. However, if it is passive or stable, usually patient will not have those sensitivity. Why? Because there is a reparative dentin already built up. Okay. So, and etiology, perhaps a patient if actively doing habits or in passive or stable, probably the habit was controlled or perhaps absent. Okay. So these are index that you can use to sort of monitor the patients in terms of the progressions. So there's a couple of index I can share here. So one of it is Smith and Knight Tooth Wear Index. 1984 is basically you look at single tooth and you classify, you score the tooth. Probably 0 to 1 probably is sort of physiological, 2 to 3 is moderate tooth wear, and 4 we can classify it as severe tooth wear. This is good. This index is good for you to monitor. So for example, you're going to monitor, you see this patient this month, and you're going to monitor the patient perhaps another 3 months. So you can use this index to just to see whether is there any active progressions or not. And we talk about the base. It's another tooth wear index we can use, but this is developed by Bartlett, 2008. So actually, this is for erosive wear. So it's similar to the way that you're doing your basic periodontal examinations, PPE. So this is where you divided the tooth into section, and you just score the tooth which is more severe. Okay. So you can see here, this E1 is enamel affected. So 2 is quite mild, and 3 is sort of moderate or severe tooth wear. Okay. So in BV, the battle also sort of suggesting the managements. So if it is low, so perhaps you do the maintenance, you do the observations, and perhaps you advise the patient on certain habit that can cause the problems. If it is medium, so you want to consider doing any fluoride therapy to just treat the sensitivity if there is any, and you want to review, and if it is high, perhaps but also suggesting a few managements that you as GP can easily do the managements. So if you talk about tooth surface loss, you can always you can see the occlusal vertical dimensions. So there is two scenario, whether the patient presented without loss of OVD or patient with loss of occlusal vertical dimensions. So without loss of OVD, you see there is tooth surface loss. There is the tooth, for example, there is more than 1/3 of the clinical crown height loss. But you see the OVD is about right. Why this happen is due to the dentoalveolar compensations. So despite where there is a movement that going on to maintain the occlusive occlusion contact. And what are the clinical signs? You can see the occlusal surface sort of flattened, but you can see the facial proportions. The lower facial height is about right, and you see. So in this case, we can say that there is no loss of OVD because there is dentoalveolar compensations, and this occur in gradual loss or gradual to surface loss. However, if you see certain patients with loss of OVD, you can see when patient about to close the mouth, there's over closure or the face, lower face height is sort of collapse. So it can due to the severe to surface loss, and this severe to surface loss occur within short period of time. Okay, so there's loss of LVD. So, for example, in this patient, so the LVD is about right. I understand it's quite difficult to tell from these photos, but it's something that perhaps you see that this is about right. But however, if you see this sort of patients, so you see when patient close, there is overclosure of the lower facial height. Okay, so this is without loss of OVD. So this is OVD is maintained due to dentoalveolar compensation. So these are important for you to assess as well in terms of the occlusions. So you assess the static and dynamic. If you're about to restore any tooth or any tooth loss or any missing teeth, you want to check if there is any restorative space. And if we look, if about to approach the tooth surface loss, we have it's either conformative or reorganized. But most of the cases, the way that we approach the two surface loss is effectively do the organization or full mouth rehabilitation. And of course, if you want to prescribe the patient with reorganized push, so we can why body is ideal. And then keep in case you end up that you want the patient with function.
Dr. Mohammed, so sorry to
Yes.
interrupt.
Yes.
Your voice is breaking, sir.
What about now? Is it still breaking?
It's great now. Thank you.
Is it okay now? Okay, good.
Yes.
Yeah, okay. Okay, sure. Thank you. Thank you. And then in terms of the assessment, so most of the problems with the tooth surface loss is actually we don't have enough restorative space. So just imagine if you encounter such patient in your practice, how can you restore, for example, the incisor edge from the patient with this current occlusal vertical dimension? Are you able to restore? Yes, you're able to restore, but patient end up come back with fracturing of the restorations. So these are the things you want to assess whether you are capable in doing or not. Okay, and of course, these are mandatory for you to assess the gingival health, the oral hygienes. You have to motivate as well because patients gonna embark on the long treatment, which is any restorations that need to be done. If patient have professional habits, then you have to provide the patients with mouth guard to protect the extensive restoration at the end of the treatment. And while patients before the patient receiving treatment as well, you have to provide the mouth guard to just control and stabilize the tooth wear. So back to the patient main complaint, what's actually patient want to achieve? Certain patient is fine with this sort of short teeth, but they just want to treat the hypersensitivity because of the tooth surface loss. So you have to look the patient at as an individual. You cannot generalize your treatment plan to all patients. Okay. So again, is occlusion favorable? So like I mentioned earlier, is the space is there or not? does the patient require any orthodontic treatment just to align the tooth so that it will be easier for the restorations later on? What about the patient financial status? Is patient able to afford such complicated treatment or not? Then this is the thing that you have to discuss. And of course, if you're going to talk about the restorative options in restoring tooth surface loss, you can talk about indirect or direct restorations. And what about whether you're going to provide the patient with interim, for example, composite as interim, and you're going to convert that into any indirect, for example, porcelain or any zirconia restorations. So, like I mentioned earlier at the very beginning, the prevention is most important thing that you have to master as general dental practitioner in order so that you can prevent the progression of the surface loss. So the first is actually dietary advice and modification. If from your history or diet history, you find out the patients have high frequency of acidic diet, then perhaps you have to advise and you have to make sure patient understand the cause is actually comes from his diet, blah blah blah, and you have to make them taking part in the treatment. And if patients, you suspect that the patients have any sort of medical problems that cause intrinsic acids, you may want to refer the patients. Or if patients are already diagnosed with the problems, you may also want to refer just to make sure the disease are controlled by our medical colleagues. And of course, oral instructions is important, and it's important for patient as well to have a very ideal or correct technique of the toothbrushing. So example, the etiological factors from abrasion is coming from the vigorous toothbrushing. So this is where you want to make sure they understand. And the fluoride applications, if patient have any sensitivity, remineralizing solutions, for example, CPP, ACP, any desensitivity agent you can use, perhaps this simple as bonding agent. Occlusal spleen, if you really confirm that patient have the parafunction habit, bruxism, you may want to give patient occlusal spleen so that we can stabilize the patients. It's very difficult to treat the patient with active grinding habits because yeah, it's quite difficult to find out stable positions of the jaw relations later on. So that's why if patient have prior functional habit or any grinding habits, so occlusal spleen is a must for you to provide at the very beginning of your treatment approach. And perhaps you can provide with sort of just glass ionomer cement, a very thin layer, just to cover up the dentin to make sure the sensitivity at least controlled. Okay. So the primary goal in the prevention is actually we want to prevent the further pathological wear, so that the wear rate may return to physiological instead, not pathological anymore. So we are always in dilemma whether we're gonna restore or not the tooth. So like I mentioned earlier, reason for the patient is important. That's gonna help us as well in whether okay, this case we decide we're gonna restore it. Okay. What about this case? This case perhaps we control first, then only we think of and we can suggest the patients. Okay. If it's not restorable, then we tell the patient. And reason for the clinician to start the treatment, of course, we look at into primary factors and secondary factors. If the amount tooth wear is just minimal, probably patient may not need doesn't need treatment. The affected surface perhaps is not severe, and the number of affected to whether it is localized or generalized. And the other factors, progression of wear. So if it's actively progressing, then you may want to start with your preventive measure first, then only you go ahead for the next phase, which are restoration. And age. Is patient okay? Is patient are the right age for you to restore, or patient is quite old? can't stand at the dental chair for a long time. So that is the thing you have to consider. The etiological factors, is that the etiological factors being controlled or not controlled? So if it's controlled, then you can move ahead with the restoring. If it's not controlled, then you have to really involve the patients in understanding the problems. So when not to resolve, of course, if just a very minimal enamel wear and patient doesn't have any symptom, doesn't have any complaint, no aesthetic concern, and is in stable conditions. So if you look into the patients, like I mentioned earlier, how you can identify whether it's pathological or physiological, you want to look into the age for the patients. So if it's pathological, yes, probably you need the treatment. But however, risk assessment is mandatory. You have to consider the etiological factors and you have to establish the prevention program. And once you involve the patient in preventive measures, you have to review the patients and you have to monitor the patient. Okay, once the sort of the habit is sort of controlled, so then you can move into the other part, which is going to formulate the restorative interventions. But if it is no, then you have to go back into the preventions again. So it's sort of cycle, and patient have to understand that, because when you provide any restorative treatment in patient who does not control their habit, so it's gonna aggravate and it's gonna cause more problem instead. So because I mentioned that you have to monitor. So how can you monitor? So just now I share a few index you can use to monitor, or it's good you have a study models, or you just have the intraoral scan, the IADS digital intraoral scan, for you to just compare the progressions. And if you can have a good clinical photos, you can show the patient as well, and you can retake the photos once you review the patient, probably 6 to 12 months after that. So you can see if it is actively progressing, then you have to let the patient know. So the tooth surface loss is progressing. So uh, we just want to make patient aware that the problems. Okay, so by having that, so it will involve active participations from the patient to just control the tooth surface loss. So this is example of the cases that they did. So they review the patients after about 3.5 years, and you can see the progressing is about stable, right? You can just compare here intake and 3-year recall. So you can't really sort of give distinct differences between both, which is good. So next we move into after the patient control, the etiological factors is control, patient sort of entering the stable phase of the tooth surface loss. What are the principles of restorations? So the first one is always postpone until the patient is compliance, not only the habit of that cause the tooth surface loss, but in terms of the oral hygiene. Patient have to have a very good oral hygiene in order for the patient to embark on the more extensive restorations. And patient must understand all the risks and benefits, and we have to go for additive rather than substitutives, because we want to conserve what the patients have at the very beginning of the treatment. So restoration should be conservative as possible, and the tooth preparation, if there is any, should be restricted to just creation of any features that to just facilitate the restoration placement. For example, seats, bevel, or chamfer, and a selection of materials or technique have to take account which are the patient expectations, whether the patient have high aesthetic expectations, whether the patients have other risk profile that you want to take account. For example, patient is frontliner that work with a lot of social interactions, and you want to see whether the patients have budgets, of course, and you have to judge your skill as well in terms of providing such invasive or such extensive restorations. So you just table just to just give sort of advantage of direct restoration. Of course, it is low cost, less invasive compared to the high cost of indirect restorations. So hybrid composite better than microfill composite. And if you look into the literature, European Consensus 2017 agreed on the minimally invasive technique in treating the tooth surface loss by using the adhesive material. So the keyword is actually additive rather than subtractive, because you want to maintain as much the tooth structure the patients have in order, because the tooth is going to stay for a longer time, right? So material of choice, if you look into the literature, you can see if they use the direct composite build-up, you can say that about 97% survival rate in 5 years, which is reasonably good for the direct composite. And if you look into the survival rate of the any onlays or glass ceramics or any phosphatic porcelain, so it can 90 years in 10 years. So these are the things you want to discuss with the patients. Okay. And if we look into more literature, they look into different restorative options from direct composite, indirect composite, or porcelain veneers. But the conclusion from this systematic review, they said that there's no strong evidence suggests any material better. Direct or indirect restoration may be feasible options to restore severely worn down teeth. But again, if you look into the European Consensus 2017, so they're suggesting additive rather than subtractive or minimally invasive. So these are another paper that look at into the just using the direct composite build-up in management of toothwear, severe toothwear, and they've seen only 70 out of 1,000 restoration failed during the follow-up, which is reasonably good considering the direct composite is quite conservative, and we didn't cut, we just probably roughen or chamfer the tooth surface. And these are the series that they've started the restoration when the patient just 22 years old, presented with severe tooth wear back in 1995. What they did, they just build up with direct composite build up. And you just imagine if you use the conventional approach in tooth wear, where we cut this tooth to do the crowns, what will happen to the tooth? I bet this after 16 years, the tooth not going to survive in his mouth. Okay, so that's why it's important for you to go for additive or any minimally invasive first before you proceed with any conventional approach, which is, for example, conventional crown preparation. Like I mentioned, when you assess the patient, the problem is actually lack of space. So there's a couple of methods that can be used to achieve the space for the restorations. Probably this is the old approach, conventional approach, where you do the reductions, occlusal reductions, to just gain space for your restorations. Or you can reduce, which also reduce opposing to, which is also quite aggressive or quite destructive to the tooth. Or you can use occlusal equilibration, which means that you use the slide available, the position from the retrograde contact position to intercuspal position, where the patient occlude maximal intercuspation. Or you can advise the patient with conventional orthodontic, where you provide dilated movement to just create the space for the restorations. Or fifth, you can do dial approach. What is dial is basically you place the restoration supra-occlusions to add increase of VT. So then you allow the tooth to undergo intrusion and extrusions. So perhaps the anterior teeth gonna undergo intrusions and the posterior teeth gonna extrude to gain back the occlusal contact. And these are other things. Crown lengthening basically doesn't create the space, but increase the retention and resistant form for restorations and the increasing OVD. Probably usually we combine with dull approach and increasing OVD. So this is basically a reorganized approach or in full mouth rehabilitation. Most of it we combine the approach to just gain the space for our restorations. And again, these are a nice flow chart for you to just go through. When you're about to decide whether you want to go for the restorative intervention, perhaps you want to take any occlusion relationship, for example, centric relation, and how much most of the practitioner would like to ask how much the OVD that they're gonna increase. It all depends on the aesthetic needs from the patients. But usually the maximums that we can go is actually we increase by the 5 millimeters OVD. Okay, and then once you have the all the records, you can do the wet up, and from the wet up you can do the mock up just to assess with the patient, and during that visit you're gonna have a patient consent. So the treatment plan, how you formulate a treatment plan, of course, there's always emergency. If patient have, for example, severe sensitivity, perhaps you want to do desensitizing first, then only you think of other things. You want to control the patient investigation and stabilization. You want to control the progression of the tattoo by having a diagnostic model. This is the way that you take the jaw relations, centric relations, and whether how you're gonna increase the OVT, whether you're gonna use composite or removable. And the rehabilitation phase, what are the treatment, what are the method of choice, whether you're gonna go direct composite or you wanna go indirect porcelain or zirconia or any metals, and maintenance phase, which is protective appliance or occlusal splint. So back to the case that I've showed earlier. So how we're going to approach the case? Of course, it depends on where you work later on in practice. If you have all the capacity to treat to surface loss, then by all means, if you have the strong foundations, then you can treat the patient. But if you sort of, 50-50 about the treatment plan, you can always refer to your nearby specialist just to get the treatment plan. So in order for you to have a good treatment plan, in order to better management for the patient. So back to the case. So patient is 40 years old, which is quite young, and patient complained of one down and short teeth. So this is something to do with the social interactions, and patient does not like smiling and talking. So this is something to do with self-esteem from the patient. So our duty is basically at this stage, we want to control the progressions. So what are the etiological factors in this patient? Basically, actually, patient love to drink fizzy drinks and carbonated drinks. A lot of fizzy drink, carbonated drinks. But when the patient was referred to me, it's actually 1 month after the patient seen the GP. So the GP already tell the patient and consult the patient, and the patient sort of already stopped the what we call that, the habit, the offending habits. However, you still have to monitor. Still have to give patient time and monitor the patient. That's why you have to take certain photos just for you to identify, is that true the patient stopped the habits. So you just want to see the progressions. Once the progressions is sort of stable, and patients also motivated enough to just embark to further restorative treatment, then we start the treatment. So that's why we have to start the patient with a good west up. So this west up was made at increased OVD. I think we increased the OVD about 3 millimeters in this patient. You can see the expressions are posterior teeth. We just do west up of anterior teeth. And in this case, we're going to approach using dial concept. And we do the mock-up. Mock-up is important for the patient to visualize what are the things that we're going to achieve to the patients. Okay, so let's say, doctor, I don't like this sort of appearance. I want my lateral incisor to be longer. So by all means, that you can always adjust your west up here to just make longer. Then once the west up is adjusted and patient agree, this is where you take the consent, of course. And in this case, what I did is actually I do the composite build up 3 to 3, upright 3 to 3, and then and also lower right 3 to 3, and using the injection molding. So you notice there's separations of the posterior teeth. Yeah. So I allow the tooth to supra-erupt or to dull. Dull consists of some percentage of intrusion of anterior teeth, and when the tooth is separated, so there is always extrusion. Why this extrusion occur? Because the tooth is finding their pairs to occlude well. Okay, how but in certain teeth which is affected by the tooth surface loss, I put the GIC because I don't want the tooth to supra-erupt. I just want the posterior molars to supra-erupt. So this is the tooth because at the end of the treatment, I'm going to provide at the middle of the treatment, I'm going to provide these premolars with the something which is more permanent, which or definitive, sorry, which is lithium disilicate onlays. Okay, you see onlays here, and I also replace the missing teeth here, which is by resibonate bridge. So this is a completed case, 4 months. So you can see the occlusion is re-established. Perhaps there is crossbar here, but it's fine. We can monitor the patient still. And this is after. Okay, and at the end of the treatment, it's important for you to liaise with your referral dental practitioner to just see to continue the treatment in reviewing the patients. Of course, like I mentioned earlier, you have to provide the patient with sort of any protective splint or occlusal splint at the end of treatment to protect your extensive restoration here. So as general dental practitioners, it's important for you to know when to refer or when to consult. Of course, if this patient having their generalized severe tooth wear, this is the thing that you want to consult first, or is there any collapse or vertical dimension of occlusions, or the occlusions is seems a bit complex for you to manage, and it sort of involve multidisciplinary, for example, perio treatments and whatnot. And this is sort of common mistakes in managing tooth wear. First of all, it's actually restoring without addressing the cause. Like I mentioned earlier, identifying the etiological factors is important so that the patient will enter into the stabilization phase before you start restoring. Over prepare. So like I mentioned, we want to maintain any tooth structure the patients have. We don't want to cut more. And ignoring any medical causes, that's why you have to liaise with your medical colleagues so that we manage patient as a whole, and increasing video unnecessarily. So most of it is about 5 millimeters maximum, which is fine to get good aesthetic outcomes. So this is just outline against, I'm not going to read it, but from this, it's actually the prevention is important, and restorative treatment should be conservative as possible, which employ the concept of minimally invasive. So I think I've come to the end. Like I mentioned earlier, tooth surface loss is common, but most of the time it is underdiagnosed. So diagnosis precedes any restorations because we want to prevent, or we want to make sure patient actively participating in the management, and we will have to use the minimally invasive technique whenever possible. And of course, if it is too complex beyond your scope, you can always refer to at least have a good treatment plan. So in order for you to manage a patient with any kind of tooth surface loss. I think these are my references. Thank you very much for the attentions. I think back to Ms. Safia.
Thank you, Doctor, for your lecture, but we are moving now to the Q&A. So there is a question saying, can the doctor give us an example of the aerative restoration and how long the surface is prepared?
Okay. So you want to go one by one? Okay. Okay. So perhaps the when I mention additive restorations, so the additive restoration here is actually referred to any direct restorations. For example, composite restorations, glass ionomer cement restorations, or any restorations that is available in your clinic. So additive is referred to anything that you can easily patch the restoration. However, to patch those restorations, perhaps it need a very proper planning. Like I mentioned earlier, you have to do sort of build up. You have to do west up, and you have to see how much that you're gonna patch. So additive refer to direct composite restorations.
Okay, thank you. There's another question is saying, hello, Dr. Mohammad. I would like to ask why you have decided to place onlays instead of composite build-ups on the premolars in the case you have shared.
So basically, on that particular case, I want to have a better or stable contact or stable in terms of the restorations. If you look into the composite a few problems with direct composite build-up. One of it is stain. Second, composite also can worn down if patient have actively progressive. So by putting the onlay, the lithium disilicate onlay, so I can easily control that the onlay not gonna wearing down. So let's say the patient came back to me. If patient lost or defaulted the follow-up, the patient came back to me after 5 years. I believe that the OVD that I've created is still maintained, and I can easily patch or do the composite build-up of anterior teeth. That is the reasons why. I
Okay,
hope
someone
it's
is
answered the
asking
question.
if kindly share the links of the papers. Yes, you have answered the
Uh,
question.
yeah, yeah. I
We can
did
do-
put in my references, right?
Okay, someone asked if there's kindly share the papers, the link of the papers in the group.
Okay, I can give the email of the list of references.
Okay. There's another question. Hello, does the increase of not cause temporomandibular joint pain? Do you cooperate with the gut gloss during cases like this?
Can you repeat the question again?
Hello, does the increase not cause temporomandibular joint pain? Do you cooperate with the gut light during cases like this?
Okay, perhaps if you encounter such cases, that is why in your examinations, if patient have any, for example, TMJ or pain or any TMJ PDS pain dysfunction syndromes, you have to stabilize the patients first. Okay, so that's why refer to our for example, oral medicines or any medical dental colleague that specialize in the TMJ is important for you to control the TMJ pain first before you embark into increasing the OVD. If you increase the OVD, if patient doesn't have any TMJ pain, uh, usually increasing the OVD about 5 millimeters, like I mentioned earlier, is okay, not to cause the patient TMJ PDS, TMJ pain. But you have to warn the patient there's going to be a period of discomfort. There's going to be a period of discomfort from the patients, but things we get all better and better with time.
Okay, thank you, Doc.
So I think that the short message is actually, if patient have actively pain on TMJ, it's important for you as practitioner to control the pain from the TMJ first, then only you embark into more definitive plan.
Okay, well answered question, doctor. So far there's no more question, but we will for 1 minute. If there is anyone want to give another question.
Cool. Thank you. So basically they're joining from the YouTube live, right?
Yes.
Okay.
So we will see the comments there. Okay, there's a last question. Is saying when using the Dell technique, and for example, you have decided with increasing the oft by 4 millimeter, will you do it in two phases of 2 millimeter or 4 millimeter at once?
Most of the case that I did the treatments, I do all at once. Uh, but okay, there's two approach in dull. It's either you doing something which is fixed, like I did earlier in the case that I've shown, which I've used the composite to as dull to increase the occlusal vertical dimensions, or you can use any removable prosthesis. For example, you do sort of the cobalt chrome dentures just to increase OVD. Uh, uh, but the using the remover gonna require the patient to sort of cooperate in wearing the device and with wearing the prosthesis. So to answer the question, most of the times I did just once, just one stage for M straight away. But I have to warn the patients that for first few weeks that he gonna sort of felt a bit strange and discomfort, which things gonna get better and better with time. Yes.
Okay, thank you, doctor. There's another question. During the investigation and stabilization phase, what's meant by testing of increasing vertical dimensions, and how would we imply the removable applicants?
How can we test the com the
Vertical
compliance,
dimensions.
the
Yes.
vertical interventions? So
Yeah.
how much that we're gonna increase again depends on the aesthetic demand from patient. That's why we have to do the WhatsApp or the mock-up just now. Okay, how are we gonna test whether the patient is compliant or not? Usually, after a few weeks, we're gonna call the patient back to review. So most of the patients, let's say a patient doesn't have any history of TMJ pain. For example, from your pre-treatment assessment, it's actually patient doesn't have any TMJ pain. But however, 3 months after, 3 weeks after that, or 2 weeks after that, you when you review patient with the increase of VD, you sort of patient complain of suddenly there's TMJ pain. So this is one of the clinical signs that perhaps the OVD that you give to the patient is too much. Okay, too much. But uh, if you're doing something removable, you can easily trim. But if you're doing something which is fixed, composite build-up, you can always polish and reduce the height. So one of the ways is actually look at the compliance. But to tell you what, most of my patients that I've done, once they have the mindset, once they are motivated, usually uh, as far as I do the treatment into surface loss, I haven't seen any sort of patient is not okay with that increase of VD. Most of the patients are fine, are doing okay.
Okay, doctor, thank you. Thank you, Dr. Mohammad, so much for delivering such an insightful and engaging webinar. We truly appreciate your time, effort, and the valuable knowledge you shared with us. It was a pleasure to having you with us today. Dear participants, kindly note that the QR code for attendance will remain visible on the screen for 5 minutes only to allow participants to scan it and complete the form. We would also like to thank all participants for attending today's session. We look forward to seeing you in our upcoming webinars. Thank you so much.
Again, thank you very much to the invitations to the International Association of Dental Students, right? Thank you very
Yes,
much.
you're welcome. Goodbye.
Bye-bye.